Welcome to Math Simple. Today our topic is osteoarthritis or degenerative joint disease, which is the most common form of arthritis. It is a chronic, slowly progressive condition which is characterized by focal loss of articular cartilage, subchondral osteosclerosis, osteophyte formation at the joint margin, and remodeling of joint contour with enlargement of affected joints. The prevalence rises with age, and it has been estimated that 45% of all people develop knee osteoarthritis and 25% develop hip osteoarthritis at some point during life. Osteoarthritis is a complex condition influenced by both genetic and environmental factors. Degeneration of articular cartilage is a key feature of the disease. In the initial phases of osteoarthritis, chondrocytes multiply and form clusters, while the water content of the matrix rises and the amount of proteoglycans decreases. Collagen type II fibers in the top layer of cartilage are broken down, leading to fissures and gaps on the joint surface. This causes a rough, soft surface. Over time, the cartilage cells die and sections of cartilage break off. These loose pieces, along with bits of bone underneath, can move around in the joint, forming loose bodies, known as joint mice. This can result in cartilage damage and decreased thickness over time, which is initially focal. Now, when the subchondral bones get exposed, it becomes a new articular surface, which by friction smoothens and gives off a polished ivory appearance. That is also known as bone hibernation. Small fractures are common in this damaged surface, which allow synovial fluid to enter and form fibrous walled cyst. It is also accompanied by abnormalities in subchondral bone, which becomes sclerotic, meaning it hardens and forms a subchondral cyst. Fibrocartilage is produced at the joint margin, which undergoes endochondral ossification to form osteophytes. Individuals with osteoarthritis tend to have a higher bone mineral densities in areas away from the joint, which can contribute to the formation of bony spurs. The outer capsule of the joint also thickens and tightens, providing support to the remodeling joint. The muscles surrounding affected joints commonly show evidence of wasting and non-specific type II fiber atrophy. Calcium pyrophosphate and basic calcium phosphate crystals often become deposited in the abnormal cartilage. The risk factors for osteoarthritis are the genetics that include skeletal dysplasias, developmental dysplasia of the hip, slip femoral epiphysis. These abnormalities are due to the abnormal load distribution across the joint. Occupational risks are for farmers, which are at risk for hip osteoarthritis, minors for knee osteoarthritis, elite athletes for knee and ankle osteoarthritis. Unfavorable biomechanics are due to meniscectomy, ligament rupture, Page's disease of the bone. Obesity due to cytokines that are released from adipose tissue may play a role. Trauma may cause unilateral osteoarthritis, and some hormonal factors such as estrogen deficiency, because estrogen suppresses bone resorption, and aromatase inhibitors, which inhibits the formation of estrogen. The most common presentation for osteoarthritis is pain and functional restriction of joints, which is relieved by rest. It is most symptomatic in weight-bearing joints, that is, hip, knee, and ankle. Distal interphalangeal joints are more commonly affected in the hand compared to the proximal interphalangeal joints and metacarpophalangeal joints. Crepitations of the involved joints are common, while effusion is rare. Osteoarthritis causes pain in only one or a few joints, which is of insidious onset over months or years. It is of variable nature. Some days are good and some days are not. Morning stiffness is of less than 15 minutes. Pain which gets relieved by rest causes a phenomenon known as gelling, that is basically stiffness and feeling of immobility after continuous rest. The clinical signs of osteoarthritis are Restrictive movement due to capsular thickening or blocking off by osteophyte, palpable, sometimes audible coarse crepitus due to rough articular surfaces, bony swellings around joint margins, any deformity usually without instability, periarticular tenderness, surrounding muscle weakness and wasting. For mild or absent synovitis, an intelligent gait in case of knee and hip osteoarthritis. The most common type of osteoarthritis is the generalized noodle, which has a genetic component which begins at around 40 years of age and has a female preponderance. These gradually develop posterolateral swellings on each side of the extensor tendon, which expand and harden to form Heberden's nodes, which is in the distal interphalangeal joint, and Bouchard's nodes, which is in the proximal interphalangeal joints. Involvement of the first carpometacarpal joint is common, leading to pain on trying to open bottles and jars. Clinically, it may be detected by the presence of crepitus on joint movement and squaring of the thumb base. The knee osteoarthritis primarily affects the patellofemoral and medial tibiofemoral compartments at the knee before spreading to the entire joint. It typically affects both knees symmetrically. Pain is usually felt in the anterior or medial side of the knee and upper tibia, especially when going up or down the stairs. Activities like walking, standing up from the chair, getting in and out of the car, bending to put on shoes might be challenging. The local examination findings may include a varus or less commonly valgus or a fixed flexion deformities. Hip pain is usually felt tenderness just lateral to the femoral pulse and can radiate to other areas. Lateral hip pain may indicate trochanteric bursitis when lying on that side. Hip osteoarthritis most commonly targets the superior aspect of the joint. It is often unilateral at presentation, has a poor prognosis. The less common central or medial osteoarthritis shows more central cartilage loss and is largely confined to movement. It is most often bilateral at presentation. The examination may reveal pain and restriction of internal rotation with the hip flexed. It is the earliest and most sensitive sign of hip osteoarthritis. Fixed flexion, external rotation deformity of the hip, ipsilateral leg shortening. Osteoarthritis commonly affects the cervical and lumbar spine, known as cervical spondylosis and lumbar spondylosis. Symptoms include localized pain in the neck or low back, with possible radiation to the arm, butt, and legs due to nerve compression. Pain is usually worse with movement and better with rest. Physical examination may show limited range of motion, loss of lumbar curvature, and positive test for nerve compression. The erosive osteoarthritis refers to people with hand osteoarthritis who have higher inflammation, disability. Proximal interphalangeal joints are mainly targeted. X-rays show subchondral erosions, and the affected joints may develop ankylosis, and there is lack of association of osteoarthritis elsewhere. The common tests that are done for the diagnosis of osteoarthritis are the laboratory tests, in which ESR, CBC, ANA, and rheumatoid factor are all found to be normal. The most accurate test for osteoarthritis is the radiography of the affected joint, in which the X-rays show joint space narrowing, osteophyte formation, dense subchondral bone, and bone cyst. The different radiological views taken for osteoarthritis are non-weight-bearing posterior anterior pelvis X-rays for hip osteoarthritis, while standing anterior posterior X-rays for knee osteoarthritis, and flex scalene view to assess patellofemoral involvement. Plain X-rays are done for spine osteoarthritis, which can show disc space narrowing and osteophytes. MRI is needed for suspected nerve root compression or spinal stenosis. Synovial fluid aspirate can be done from an affected joint, in which synovial fluid is viscous with a low cell count. The upward-most differential diagnosis would be of rheumatoid arthritis, which can be distinguished by the absence of inflammation, normal lab test, and short duration of stiffness, which in rheumatoid arthritis is more than 15 minutes. The patient should be informed that structural changes are permanent and a cure is not possible. Only pain and function can be improved. The treatment contains of lifestyle modifications, such as weight loss and doing moderate exercise, in which hydrotherapy, swimming, tai chi, and yoga are effective. Acetaminophen is the best initial analgesic. Topical NSAIDs are used if symptoms are not controlled with acetaminophen. Oral NSAIDs should be considered in patients who remain symptomatic. Other medicines are capsaicin cream, strong opiates, duloxetine, glucosamine and chondroitin sulfate, however, are no more effective than placebo. For specifically knee, quadriceps strengthening exercises, shock-absorbing footwear, acupuncture, and transcutaneous electrical nerve stimulation, intra-articular injections of hyaluronic acid, intra-articular glucocorticoid injections are effective in the treatment of knee and for the first carpometacarpal joint. Use of a walking stick for painful knee or hip osteoarthritis is also effective. For patients with osteoarthritis who continue to experience significant symptoms and limitations, despite trying various medical treatments and lifestyle changes, surgery may be a necessary option. The most common surgical intervention for osteoarthritis is total joint replacement. Osteotomy is sometimes done to extend the life of misaligned joints and reduce pain by decreasing pressure within the bone. Cartilage repair is also done to address specific cartilage defects. With this, our video comes to an end, and don't forget to subscribe. That's simple. Thank you.